welcome to those of you who haven't been to the seminar before. So I'm Simon Picard. Chris is a fellow with me through the UIC Takeda Health Economics Fellowship, and Chris is also in the second year of his PhD. And this project that Chris is going to present today is on the treatment utilization in elderly diffuse large B-cell lymphoma patients with cognitive impairment and dementia. So we're looking forward to hearing from you, Chris. If you can hold your questions until the end, that'd be great, unless it's going to help to clarify things for the entire group. So please help me welcome Chris Saffore.
So thank you, Simon, for that warm welcome. So I'd like to begin with a few acknowledgments. Doctors Caleb and Chu for allowing me to utilize their data and analyze it for this presentation today. Also to Greg for his guidance and assisting me in putting this presentation together. Shruti, Katie, and Jenny, I only see one of the three here. Thank you all for your help whenever I bug you about data questions. Just getting through this, I appreciate all the help you've given me. So the outline for today is going to go as follows. So introduction, looking at introducing diffuse large B-cell lymphoma and also cognitive impairment or dementia, the methods, the results, discussion, limitations, and then also a conclusion. So introduction. So starting from the top here. So lymphoma is the most common type of blood cancer. There's two classifications that come from that. It's going to be Hodgkin lymphoma and non-Hodgkin lymphoma. We're going to focus today on non-Hodgkin lymphoma. Within that, there's two groupings by growth velocity, so indolent and aggressive. And we're going to focus on the most common aggressive subtype, which is going to be diffuse large B-cell lymphoma. So like I said previously, it's the most common and aggressive type of non-Hodgkin lymphoma. It accounts for about 30% of all non-Hodgkin lymphoma cases in the U.S. It occurs slightly more in men, and risk increases with age. So median diagnoses at about 64 years of age. So approximately 60 to 70% of all patients are diagnosed with advanced stage DLBCL, and which I'll refer to it as that from now on, which is Ann Arbor stage 3 or 4. Median survival is about less than 1 year if no treatment is received. But there's highly effective treatment available with standard multiple chemoimmunotherapy. Approximately two-thirds of all patients, or two-thirds of patients, sorry, not all patients, but two-thirds of patients go into remission. So speaking about this highly effective therapy, we have rituximab, which qualifies under immunotherapy, and it's a monoclonal antibody, binds to CD20 on the B cell, diffuse large B-cell lymphoma, and it primes the B cell to be attacked or destroyed by the chemotherapy, which is cyclophosphamide, an alkylating agent, hydroxydownarubicin, which is a anthracycline, oncovin, vincristin is the vinca alkaloid, and prednisone is the steroid. This regimen here is known as R-CHOP, so a combination of chemoimmunotherapy as a current standard of care. Radiotherapy, included here at the bottom here, just to show that it can be used to augment CHOP. This is not standard therapy, and it may be a palliative treatment option for very elderly or frail patients, and those who are unable to tolerate CHOP. So in going on about R-CHOP versus CHOP, prior to 2002, standard treatment for DLBCL was multiple chemotherapy, including CHOP or CVP. CVP would just be the regimen without the anthracycline. R-CHOP, so it demonstrated good safety and response in DLBCL patients in phase 2 studies, and then there were several randomized trials that proved greater efficacy adding rituximab to CHOP in elderly DLBCL patients. So event-free and overall survival, those were significantly higher in the R-CHOP group. Risk of treatment failure and death, those were significantly reduced in the R-CHOP group versus the CHOP group. And R-CHOP prolonged event-free and overall survival in elderly patients with DLBCL without a clinically significant increase in toxicity. Here are two graphs from one of the randomized controlled trials. And you can see here on the figure 1 is looking at event-free survival, and figure 2 is overall survival. You can see the clear distinction. The dark black line is going to represent R-CHOP, clear distinction and increase in survival from both of these graphs here. So now to switch it up, or let's start from the top again, this time we're going to go with cognitive impairment and dementia. So cognitive impairment, simply there's a presence of some sort of memory difficulty or impairment, but the patient is able to continue on with their function in life, okay, the ability to function, no issues. But they're at an increased risk of dementia. Dementia is going to be the same thing. So they have some sort of memory difficulty or impairment, but they have severe impairment now with their daily function of daily life. In addition, one or more of these cognitive domains are affected, such as learning, memory, language, or complex attention. There's a few others. I didn't include them for space. Under dementia, there's also different types or different syndromes, as they call it. So you have Alzheimer, which is the most common, Lewy body, frontotemporal, and vascular. And the diagnostic approach most commonly used is the mini mental state exam, which is about a 7-minute test in which they assess all those cognitive domains I mentioned earlier. You're assigned a score, max score of 30. If you're under 30, there may be some dementia or cognitive impairment in that patient. The mini cog exams is a lot shorter. It's more straightforward. You draw a clock, put all the numbers in the right place, put the hands, I guess, of the specific time that you're drawing the clock, and then you're asked to recall 3 words that are unassociated with each other. Based on how you do on that can determine your status for dementia or cognitive impairment. So in the elderly, the elderly population is projected to more than double, so from 46 to 98 million by 2060. Incident cases of cognitive impairment, including dementia, those are projected to double by 2050. The current prevalence of dementia is about 1 in 10 of those 65 years and older, which making up about 5.3 million Americans. That's expected to nearly triple to almost 14 million by 2050. And just a further breakdown of the 5.3 million currently, about 60% of those are women, 40% are men. Here's just a illustration of what I'm talking about as far as the 5.3 million currently, where we are in 2017, and increasing all the way to about 13.8 million by 2050. So in the elderly, risk of cancer and functional limitations such as cognitive impairment, dementia increases with age. Prevalent cognitive impairment in cancer patients may delay diagnoses and also affect subsequent treatment decisions. Elderly patients with cognitive impairment, their caregivers, also clinicians, they may be less inclined to use these curative therapies. Watchful waiting may be an appropriate choice. The patient may have a short life expectancy, so that may be a reason they're less inclined to use therapy. Advanced stage of diagnoses could also be a reason. And just the fact, just in elderly in general, they're at higher risk for these treatment-related toxicities. So an overview of the literature and existing gaps. So there have been previous studies that have shown an association between cognitive impairment and lower odds of treatment utilization. But this was seen among breast cancer patients. However, the literature is limited with regard to specifically this niche area of treatment utilization in elderly DLBCL patients who have cognitive impairment or dementia. Elderly patients, they're often underrepresented, or they're not representative of the typical elderly patient, as you or I may know, in clinical trials, and thus increasing the difficulty in decision-making by clinicians and caregivers. So my research question, so among elderly DLBCL patients, what's the impact of a prevalent cognitive impairment or dementia diagnoses on utilization of chemoimmunotherapy, that R-CHOP, and radiation 12 months after being diagnosed with diffuse large B-cell lymphoma from January 1, 2001 to December 31, 2011. My hypothesis is that chemoimmunotherapy and radiation, it's going to be less likely to be utilized in these patients, in DLBCL patients, elderly DLBCL patients with a cognitive impairment or dementia diagnoses. So my PCOTS framework, so my population is elderly DLBCL patients, looking at and separate people into groups of people that have a prevalent cognitive impairment or dementia diagnoses compared to those patients who have no such diagnoses. Utilization of any primary treatment in the 12 months after diagnosis of DLBCL. Time frame I'm looking within is January 1st, 2001 to December 31st, 2011. And the setting or database or data source we're using is Seer Medicare. So here's an illustration of the study design. So my study period, as I said, January 01 to December 31st, 2011. my index date here is date of primary DLBCL diagnoses during the study period. The baseline period is going to be 12 months prior to index date, in which we would identify CID stands for cognitive impairment or dementia. The follow-up period is going to be up to 12 months after the index date, in which we will identify primary treatment. End of follow-up is either going to be 12 months after index, end of the study period, or patient death, whichever comes first. So the data source which is used, as I stated earlier, is the Surveillance Epidemiology and Results, otherwise known as SEER, Medicare linked database. So there's linked data files that provides information on Medicare patients in the SEER program supported by NCI, National Cancer Institute, and patient-level demographics such as age, sex, month, and year of birth from the first primary tumor until death is included. So my inclusion criteria included, first primary lymphoma diagnoses, age had to be 66 or older, their eligibility or reason for Medicare had to be age-related, continuous enrollment at least 12 months prior and post, unless they died, and their primary payer needs to be Medicare. Excluded if they have previous lymphoma diagnoses younger than 66. Their reason for having Medicare is not related to age, lack of continuous enrollment, and their primary care payer was not Medicare, so HMO, Medicaid, etc. So how we went about identifying cognitive impairment or dementia was described by Amra et al. So what they did was simply, how we can only measure this, they used ICD-9 codes documented in the claims data primary to their initial cancer diagnoses. What they had, they called an electronic search algorithm. So it was developed to identify cognitive impairment separately and dementia using electronic medical record data, which was then vetted by a criterion standard, which was reviewed by an expert neurologist to confirm this. So validation, the search algorithm was validated using the ICD-9 codes to identify the cognitive impairment dementia against what the expert neurologist, against his review. The sensitivity and specificity for measuring cognitive impairment and dementia separately achieved greater than 90%. Here, you may not be able to see all this very well. It's totally fine. These are just the ICD-9 codes that were listed. These are ICD-9 codes that were listed that they used to identify cognitive impairment and dementia in their supplementary materials. How we measure our outcome is, our outcome is treatment utilization. So it's receipt of a primary DLBCL treatment, chemoimmunotherapy, so R-CHOP or radiation in the 12 months post diagnosis of DLBCL. So there's a few categories here. So there's any treatment, which consists of chemoimmunotherapy plus radiation. Any chemoimmunotherapy, which consists of rituximab plus any chemotherapy. We have rituximab-based therapy, which is rituximab plus or minus any other chemotherapy. Anthracycline, including therapy, which is the anthracycline, plus or minus any other chemoimmunotherapy. And then radiation, yes, sir. Relevant covariates included were age, sex, so male or female, race, ethnicity, white, black, Hispanic, Asian, Pacific Islander. There's no real explicit I guess information. I wouldn't say information, but in SEER to give us you're poor, you're rich. So to measure socioeconomic status, we use three variables, and it's consistent with that paper I talked about that saw the association with cognitive impairment and dementia with breast cancer. Census tract poverty level, or I'll start with the top. So Medicare supplement, either yes or no. Metropolitan statistical area, big metro versus not big metro. So 1,000 or more people a million or more people is considered big metro. Less than 1 million would consider as non-big metro. And then census tract poverty level, less than 10%, greater than 10%. Ann Arbor stages is also included, stages 1, 2, 3, and 4. And comorbidities and diagnoses were cardiovascular in nature, coronary heart disease, diabetes mellitus, and heart. So statistical analyses. So patient characteristics, we included frequencies and also percentages for the overall sample and by group. So patients without cognitive impairment and dementia and those patients with it. Continuous variables were presented with the median and interquartile range. Logistic regression models were specified to determine the crude and adjusted odds ratios and 95% confidence intervals. And we use Stata and Excel to analyze this. Okay, so the results. So here we're just going to go through how we whittled down to our final sample. So essentially, this first slide here is when we started any lymphoma diagnoses in the database during this time period. 130,000 people about were identified. When we narrowed it down to the first primary lymphoma diagnoses, that brought us down to about 101,000. Then when we want to, we only want to assess people 66 and older. So that reduced our sample size down by 31,000, bringing us down to 69,000. For patients whose reason for entitlement was not age, that was about 5,000 or so. That brought us down to 64,000. If the patients did not have continuous enrollment in Parts A and B for their Medicare and not continuously enrolled in the study, that took us down about 34,000 to 29,000 at the bottom here. And when their lymphoma case was not DLBCL, we excluded them. So that took out another 18,000 patients. And then some missing data, so unknown race or information on SES or socioeconomic status variables. If that was missing, that was excluded. So that brought us down to 10,626 patients. Okay. So table 1 here. So it's looking at the prevalence of cognitive impairment and dementia among the DLBCL cases by year of diagnosis and also by age category. So excited I got that to work. So the overall prevalence here is 3.9%. And I'll just say as you go left to right with the columns here, 2001, 2004, you see the prevalence is 3.3, 05, 2008 is 3.8, and 2009, 2011 is 4.2. So you see an increasing trend in the prevalence of cognitive impairment and dementia. Okay. Oh yeah, here we go. Okay, so as you'll see here, but as I orient you to age here, so you see the patients without CID is 77, the patients with CID 83, so they're older. Racial differences, so you see there's higher proportion of African Americans and Hispanics with CID compared to those patients in the group without CID. The next one here is looking at the socioeconomic status variables, and I didn't put anything fancy on this one. They're about the same. There's really no difference between patients with and without CID. We look at Medicare supplement, census tract poverty level, and also the metropolitan statistical area. Okay, this one here. Okay, so this one just want to show you about the comorbidities of diagnosis. So you see the people without CID, they're about 33% or so. 33% of them have consistently coronary heart disease, diabetes, heart failure, and it goes up to about 45% or so on average in the patients with CID. And last one here, just to show you the patients without CID, about 35% of them receive no treatment, nothing, no radiation, chemotherapy, nothing. Whereas almost 60%, 59% of patients with CID did not receive any treatment. So in our multivariate analyses, so any treatment, odds ratio is 0.47, and that odds ratio is consistent when it's broken down into any chemoimmunotherapy, about consistent, any chemoimmunotherapy, rituximab-based, and anthracycline including. But when you get to radiation, it's still lower odds of being treated for the people that have cognitive impairment or dementia, but it's not statistically significant. Also, I should have pointed this out earlier. On the left-hand side of the column with patients, if you look at the two columns, patients with CID and patients without CID, consistently regarding the treatment options, patients with CID, there's always a lower proportion of them that receive treatment compared to patients without CID. Radiation, there's really no difference between both groups. Okay, so then we further stratify by age group, by age category, and also Ann Arbor staging. So they're consistent with what we found so far. There is a lower odds of receiving treatment, as we stratify by age, but in even lower odds as patients are for younger patients. So lower odds. So 85 is 0.5. 85 plus is 0.5, but we see a 75 to 84 is 0.46 and 66 to 74 is 0.42. So even lower odds for younger patients. And the same trend we see for Ann Arbor stage. So still lower odds at 0.58 of receiving any treatment, but odds are even lower for stages 1 and 2. Okay, so discussion. I'm flying through this. Okay. So overall prevalence of CID diagnosis increased, although very slightly, over the study period, but it varied within elderly age subgroups. CID and receipt of primary DLBCL treatment, it was associated with lower odds of receiving receiving chemoimmunotherapy, lower odds of receiving radiation, but it was not statistically significant. And odds of receiving treatment among younger patients and earlier Ann Arbor stage patients with CID were even lower. So this lower likelihood of treatment utilization is consistent with results that have been found in other settings, such as elderly or end-of-life care, multiple or complex comorbidities, and minorities. I'll just remind you that there was a slightly higher proportion of elderly African Americans and Hispanics in the CID group compared to the non-CID group. So implications of these findings will be to influence more informed clinical decision-making, investigate that significant difference in the treatment utilization by understanding the patient, caregiver, and clinician preferences in the care of elderly lymphoma patients that have some sort of cognitive impairment or who have dementia that would be warranted. On the horizon, did a little bit of looking into this and seeing what's next, maybe, or what some different treatments could be. So R-CHOP still remains a standard of care, but current therapies are under investigation or clinical trials for newly diagnosed and relapsed refractory DLBCL. Now, I've put these into two groups, oral administration and intravenous. But to focus on the oral, for the patient, as I stated earlier, there's higher risk of treatment-related toxicities in these elderly patients, and a lot of the toxicity would be for that chemotherapy portion, that CHOP. So if there could be some sort of therapy where it's R plus one of these orals, maybe that worry could be mitigated as far as additional toxicity by providing patients with an oral therapy versus having to come in for an infusion of 4 different medications that make up that regimen. Additionally, maybe increase compliance if a medication is oral, potentially. Maybe. So limitations. So misclassification is always a potential thing happening when we're identifying patients, especially in claims or with dementia. But we try to mitigate that issue by using a validated algorithm that was able to identify patients with cognitive impairment or dementia. Also, generalizability would be limited to patients with more severe or advanced disease due to the nature of the data that we had. And then SEER Medicare does not include certain things such as claims for HMO enrollees, severity data, out-of-pocket costs, things like that. So in conclusion, so the findings of this study indicated that prevalence of CID among elderly DLBCL patients increases over time, however slightly, and treatment utilization is just less likely among elderly DLBCL patients with prevalent cognitive impairment or dementia. There's no explicit guidelines that we have for how to treat these patients with prevalent cognitive impairment. So utilization should be individualized, taken on a patient-by-patient basis. But relevant factors should be included, such as life expectancy or quality of life, when you're making a clinical decision. Future direction could be to consider new treatment options, such as the oral therapies that could replace R-CHOP, or at least the CHOP portion of it, to mitigate the worry about treatment-related toxicities and potentially increase compliance in these elderly patients. Okay, and these are my references. Yeah.
Looks just like Chris.
Yeah, I know. It took me a while to find this one. There was one with brown hair. It took me a while to find one with black hair. Yeah. So.
Great stuff. You really zipped through that, Chris.
Yeah, I speak fast.